Good afternoon. I'm Daniel Lin, and I'm a GI medical oncologist at Thomas Jefferson University Hospital. I'm delighted to be here with you today to discuss gastrointestinal cancer risk, understanding disparities. My discussion today includes defining cancer health disparities and health equity, identifying disparities in GI cancer, identifying factors which contribute to GI cancer disparities, and finally, outlining strategies to address cancer disparities to promote health equity. So first, what are cancer health disparities? A definition according to the National Cancer Institute states that cancer health disparities are adverse differences between certain population groups in cancer measures, such as incidence prevalence, morbidity, mortality, survivorship and quality of life, screening rates, and stage at diagnosis. So the goal in identifying cancer health disparities is to find ways to overcome them to promote health equity, that is, to attain the highest level of health for all people, to value everyone equally, and to promote societal efforts to address inequalities and injustice. So keeping this in mind, why is a discussion of disparities and health equity important in gastrointestinal cancers? GI cancers currently comprise 18% of new cancer cases and account for about 28% of cancer-related deaths. In 2020, more than 300,000 cases of GI cancers have been diagnosed, with nearly 170,000 deaths. And of these, more than 40% is attributable to colorectal cancer. Around 1 in 25 men and women will be diagnosed with colorectal cancer in their lifetime. Broadly speaking, disparities in GI cancer exist. Mortality is notably higher, for example, in non-Hispanic Blacks compared with non-Hispanic whites, and even more so when comparing males with females. And more specifically in colorectal cancer, which, as I mentioned, is the GI cancer with the highest incidence and mortality, and will therefore be the focus of my discussion, health disparities are evident. Colorectal cancer incidence and mortality remains the highest in non-Hispanic Blacks, followed by American Indians and Alaska Natives. And between 2012 and 2016, colorectal cancer incidence rates in non-Hispanic Blacks was 20% higher than non-Hispanic whites, with death rates nearly 40% greater. Since the 1980s, we began to see a widening gap in colorectal cancer incidence between non-Hispanic whites, which began to decline, and in non-Hispanic Blacks, which saw a period of stagnation until the mid-2000s, when incidence rates decreased similarly per year in all groups. These trends in incidence rates were reflected in mortality rates as well. 5-year survival rates remain the lowest in non-Hispanic Blacks across all stages. And non-Hispanic Blacks and American Indian Alaska Natives comprise a greater proportion of patients diagnosed with distant metastatic disease at around 25%. Disparities have also been observed in patients with early onset colorectal cancer. That is, young patients less than 50 years old diagnosed well before general screening guidelines, which itself represents an alarming cancer incidence trend. Notably, Blacks make up the highest incidence of colorectal cancer in the 20 to 44-year-old age group, compared with non-Hispanic whites and Asian Pacific Islanders, and have higher proportion of stage 4 disease and lower survival rates compared with non-Hispanic whites. So what contributes to colorectal cancer in general? Well, this can be broken down into non-modifiable and modifiable risk factors. Non-modifiable risk factors include hereditary syndromes, such as Lynch syndrome and familial adenomatous polyposis, a family history of sporadic colorectal cancer or adenomatous polyps, comorbidities such as inflammatory bowel disease, diabetes, and demographic factors such as age, gender, race, and ethnicity. Modifiable risk factors include excessive alcohol intake, smoking, obesity and its relation to metabolic syndrome, diet, and physical inactivity. So what are some of the key factors which drive disparities in colorectal cancer risk and outcomes? These can be broken down into environmental, biologic, and societal factors. The environment may contribute to more than half of colorectal cancer risk, and factors which affect colonic epithelium stem cells and impact gut microbiota, ultimately leading to neoplasia, include diet, such as high-fat red meat, obesity, tobacco and alcohol use, low vitamin D and calcium levels. And many of these factors are disproportionately observed in minority populations. In terms of biologic and genetic factors, unique differences, for example, exist in Blacks, and those include higher frequency of diagnosis at earlier stage compared with non-Hispanic whites, a higher prevalence of high-risk adenomas and right-sided colon cancer, with proximal lesions sometimes being more difficult to identify endoscopically, a higher frequency of KRAS mutations, which may be associated with more aggressive disease and worse prognosis, and a lower frequency of microsatellite instability, which itself has tended to be associated with better outcomes, and also a reduced presence of immune markers such as CD8 positive T cells and granzyme B. Societal factors such as socioeconomic status, education level, insurance access, and access and barriers to healthcare services greatly impact cancer risk. These factors may oftentimes be intertwined with racial and ethnic disparities. Lower socioeconomic status has been associated with higher cancer incidence rates, with residents of the poorest neighborhoods having a 30% higher risk than those of the most affluent neighborhoods. And lower socioeconomic status has also been associated with worse overall outcomes, and this may be linked with diet and lifestyle, as well as screening and subsequent treatment. Socioeconomic inequality carries downstream effects that impact where one lives, how they eat, what toxic habits they may develop, and what kind of access they may have to preventive health services. All of this impacts what may occur at a biological level, from alterations in gut microbiota, increase in inflammation, development of genetic alterations, and ultimately, generation of malignant precursors and subsequently cancer. In terms of preventive screening, disparities have been apparent by race, socioeconomic status, insurance status, and level of education, with still overall lower screening rates seen in non-Hispanic Blacks compared with non-Hispanic whites. So what are some strategies that can decrease racial and socioeconomic disparities? Improving patient and provider education to increase screening, implementation of patient navigation to ensure care delivery across the entire cancer care continuum, and development of comprehensive interventions to promote behavioral changes, especially in at-risk populations. Interventions to promote screening uptake include reducing economic burden, such as out-of-pocket costs for patients, and structural barriers, considering, for example, an opt-out approach to screening, and using navigation to integrate services and improve system workflow, increasing patient awareness and decreasing fears or mistrust through education and social media, and also increasing provider delivery by strengthening training and providing the resources and incentives to deliver care. Our current American Cancer Society screening guidelines for colorectal cancer now recommends screening at age of 45 years old in light of the growing incidence of young patients with colorectal cancer, though this is still a qualified recommendation. However, should factors such as race and ethnicity more prominently feature into our screening guidelines, particularly given the earlier onset and higher incidence in African Americans, for example. Finally, modification of lifestyle and behavior is ultimately the most challenging, however, may impact the biologic makeup of the colon quite significantly. Reported dietary swap experiments, for example, which swapped typical diets of African Americans who typically consume a higher fat, lower fiber Western diet, and rural Africans who consume a higher fiber, lower fat diet, show that high fat, low fiber diets increase colonic crypt proliferation and inflammation, whereas low fat, high fiber diets increase short chain fatty acid production, such as butyrate, which has been associated with tumor suppression. So therefore, long-term dietary habits may alter our gut microbiome makeup and lead to downstream biologic consequences. An intervention to improve diet and behavior will likely be meaningful in the long term. So my final take-home points: health disparities in colorectal cancer risk and outcomes are multifactorial. Understanding the interplay between race, ethnicity, biology, environment, and societal factors is crucial. Increased efforts are needed to include diverse populations in clinical studies. And education and navigation strategies may promote delivery of preventive services across the care continuum. Thank you for joining me in discussion, and thank you to the organizers for arranging such a thoughtful and impactful program. I hope everyone is well and staying safe during these times.